Right, so endometrial cancer. Now we spoke about endometrial hyperplasia in the previous lecture, and it was really short. I know it was quick and it was good. So now we're gonna speak more about endometrial cancer in total. Endometrial cancer, we have the same risk factors as endometrial hyperplasia because it's the next step, right? With no rocket science as such. So endocancer, we're gonna speak about endocancer, right? So before we get into that, there's something called as a corpus cancer. Corpus cancer is basically something that is an endometrial cancer, endocancer in obese plus obese. All right, uh, just a point that I'm throwing out there straight up. A few syndromes that you want to remember: BRCA1, BRCA1 and 2. You want to remember Cowden. You want to remember Lynch. All right, you want to remember Lynch. These are like the three syndromes that you kind of want to remember. Then you have the different types of endometrial cancer. Now we're getting serious. Now we're getting serious about endometrial cancer. Obviously, I'm not going to speak about BRCA1, 2, Cowden, and Lynch. I assume that Cowden syndrome is something that everyone remembers, right? Cowden syndrome is something everyone remembers. Lynch is something that everyone remembers. MSH1, Cowden something is PTN, and BRCA1 and BRCA2 are actually the chromosomes, are the genes itself. So I don't really want to get into it. But endometrial cancer, now we're getting into the total and into the crux of it. Endometrial cancer can be divided into two: type 1, type 2, type 1, type 2, right? Type 1, type 2. Now, when I want to talk about type 1 and then I want to talk about type 2, first of all, type 1 is something that is associated with adenocarcinoma. Type 2 is more or less it could be adenocarcinoma. Obviously it could be adenocarcinoma type 2. Okay, just let me make sure it looks like type 2, right? Adenocarcinoma, it could be adenocarcinoma, it could be clear cell carcinoma, it could be papillary, all right? It could be papillary serous also. This is something that you have to learn. I cannot explain why this is the case, but something is that it's related to estrogen. This one is not related to estrogen. So across, so because it's related to estrogen, obviously obese. This concept is something that is fairly simple to understand. Adipose converts um, any androgen to estrogen, right? And we know that in some PCOS or any ovulatory dysfunction, your androgens might be increased, right? So could be converted to estrogen. Obese, so PCOS, very important, estrogen, right? And this has good prognosis, all right? So it's good, it's safe. This one's bad, all right? So 2 is bad, but this is because of p53 mutation. Now p53 mutation is something called as a Lee-Fromeny syndrome. Again, I will not get into the detailings of it. I expect everyone to know this much. If you don't, then you need to go and watch the previous lectures, probably, if there are any. How do you investigate? As I told you, you do a USG, and that is about it. And then if it's positive or greater than 4 mm/12 mm, you need to understand this previous lecture, please. You need to do USG. If positive, then do a fractional curettage. Um, Obviously, first do a biopsy, endometrial biopsy, see what is the positive findings on the endometrial biopsy, and then go for a fractional curettage and hysteroscopy, right? And once you've got your fractional curettage and hysteroscopy in place, right? Once you've got that in place, very easily, you need to do a few steps. First, you need to perform a total abdominal hysterectomy in case it is indicated, all right? Total abdominal hysterectomy plus bilateral salpingo-oophorectomy, usually if it's a BRCA gene. You could also do your gene studies and figure out if it's a BRCA positive or not, all right? BRCA1, 2 positive. Now let's just stage the cancer before we get into the total management of the cancer. We use FIGO staging. FIGO staging is simple. It's all about 50%, and where it is involved. So if it's less than 50%, remember we are getting in the endometrium, all right? So you need to go down, all right? So if it's less than 50% of the myometrium, it's type 1. Greater than 50% of the myometrium, it's type again 1 only, but it's going to be 1A and 1B. 2 is when you're actually getting out of the myometrium and you're going into the cervix, all right? 3 is when it's going beyond cervix, so you're probably in your adnexa, all right? So you're basically in your adnexa, you're in your ovaries and in your tubes. It's 3. And 3A, B, C, C1, C2. C1 is actually, so 3A, B, C1, and the C2. So A is as you're actually in your adnexa, A for serosa, A for A for adnexa. Adnexa basically means serosa. B is actually your in your vagina. The way I say it is vagina, V and B. C1 is your pelvic lymph nodes, and C2 is your para-aortic lymph nodes. Now, there is a separate entire video about where the draining and how the draining happens. So again, I'm not going to get into the drainings. And 4 is obviously your metastasis. All right, I'm not going to get into 4A, 4B. Actually, I'll get into 4A, 4B as well. 4A is actually your bowel bladder, so your region. All right, you're around the endometrium. And 4B is actually you're going to have your inguinal lymph node mets. Now, your inguinal lymph node is something actually seen in the involved in the external genitalia, right? So your external genitalia, if this is your external genitalia, you have your inguinal lymph nodes involved in external genitalia. Now, if that is actually occurring in your uterus, so it's seen as a distant met. So, okay, so we staged the disease, we know how to treat it, right? um, in most cases, if it's a stage 1A, all right, you want to go for a TAH or a trachelectomy. Now, trachelectomy is actually, don't do a trachelectomy. Actually, you need to definitely go for a TAH. Trachelectomy, my bad, is something that we can go in cancer cervix. All right, cancer cervix. So TAH is important for 1A, TAH plus BSO. Now, you can do TAH only till a particular level, that is 2. All right, you can only do it to 2. Right, so if it is less than 2 centimeters, your lymph nodes, all right, you do not have to do any lymph node removal. All right, if your tumor is less than 2 centimeters, if it's greater than 2 centimeter, then you do your normal lymph node clearance. So that's your pelvic lymph nodes. Stage 2A onwards, stage 2, stage 3, all of those stages, you need to do your debulking surgeries if it's extended into the adnexa, and you need to clear your pelvic and para aortic lymph nodes. Actually, it's pretty simple if you think about it. That's why I'm not getting into the crux detailing of it, because you just need to remove your you need to do a hysterectomy, you need to remove your ovaries, um, if needed, not necessarily. You need to perform a radical hysterectomy. You need to do your pelvic and para-aortic lymph node clearance, and chemo and radiotherapy. Stage 3 onwards is kind of a not a must, but yes, it's done. Simple hysterectomy is basically you remove the uterus plus the cervix. So that is simple hysterectomy. That is about it. Modified radical or Wertham's hysterectomy is you remove the uterus cervix with both ovaries and tubes. That's why I'm not writing that you do a PSO. All right. When I'm saying it's a Wertham's hysterectomy, it's understood that is a PSO. All right, done already. 1 centimeter of vagina is also removed, and the middle half of the cardiac ligament, half of the uterosacral ligament, half of the uterine artery. So this has the most chance of rupture of the uterus. That's why you need to be careful. And then you have the radical hysterectomy, right? You need to know about the radical hysterectomy. And again, it's the same. It's 2 centimeter of vagina. Just that now the vagina is removed a little more. Would you remove the complete vagina? Not really. So yes, I think that is about it. And then in the next video, we'll look at CIN.